Tired.
Tired.
Mm-hmm. Hi, Professor. Good morning.
Hi, Celine. How are you?
Good, good. How are you?
Good. Good. Just waiting for a few more students. Hey, Lexi. I got your email. Stay on after.
All right.
Okay. And then put your last name on your phone, would you? It says Lexi's iPhone. Okay. We've got about 3 more students we're waiting for, but I'll get going. So how is everybody doing? Busy? Busy trying to get everything organized for the next couple of weeks. Right? Does anybody have any questions? I want to go through that announcement I sent over the weekend, the roadmap for weeks 9 through 12. I want to remind you guys that we'll get there when we do let me share my screen here. Hey, Skylar, did you get on finally? I know you were trying to get on. You there?
Yeah, I'm here.
Okay, all right. Okay, I'm going to share my screen here. Can everybody see that?
Yes.
Yes.
Okay, roadmap. Okay, so this week we've got 3 things due on Sunday. Some of you may have already done some of them. We have our third third NCLEX assignment due Sunday. We have the case study, the domestic violence and cultural competency case study. And then you have your HESI prep that's due on Sunday, and that will be used as your HESI study guide. Okay? The other thing we have going on is the exam 3 reviews. One's already been done by Professor Ford, and I sent you that recording yesterday, I believe, or the day before. I'll be doing my review after this class. And then Professor Kershaw has hers on Sunday evening. All right, so you still got a couple of more live reviews that you can go to. And then, of course, you'll get the recordings. Okay, so that's for this week. Okay, and then next week is exam week. So a week from today, you'll be taking exam 3. Okay. Also next week, your vulnerable populations paper is due. That's your individual PowerPoint assignment on a vulnerable population in your community. That's due next week. Okay, and then next week, we also have HESI reviews. Outside of class, we have 3 of them. I sent the schedule for when those 3 reviews are, and then I sent an updated schedule. Professor Kershaw had changed hers from I believe, Sunday through Thursday. From Sunday to Thursday. So next week you've got an exam, your vulnerable populations assignment, and then a HESI reviews. Okay. And then on week 11, you're taking your HESIs. I've sent out a schedule earlier in the week of the times that were posted for HESI reviews on your campuses. Do we have any? So Norfolk students, I haven't checked back to see if they've posted a date yet. Who's Norfolk? Jasmine's not here. Megan, have you heard from your campus about HESIs?
No,
HESI
nothing yet. I
Nothing
haven't
yet.
gotten an email.
All right, I'll double
No.
check. I'll double
No.
check after this class to see if Pensacola and Norfolk were posted. They weren't when I did that master schedule, but everybody else should have at least
Okay.
the day and the time that the community HESI's given. And I give you that. I have nothing to do with scheduling. That's all done through your campuses, but I like to try and give you guys a heads up as early as possible so you can start planning ahead for week 11 for when all your HESI's are. Does that make sense? So did everybody see that schedule?
Yes.
So you have an idea of when your HESI's are. Has any of the campuses reached out to anybody to start scheduling their HESI's for community?
I mean, there's a schedule posted, but they don't really reach out.
So you haven't reached out yet. So if you know the date, which most of you do, you can be reaching out to your campus to find out what the sign up process is. Okay. Week 11, we do not have class. HESI week, we don't have class. Okay. The actual sitting and taking your HESI is counted as the attendance for week 11. Okay. However, week 12, and this is important for you guys because you're a Friday class. Week 12, we have to have some kind of attendance. Okay. We won't have class on the Friday of week 12. However, in order for you guys to get attendance, you're going to have to attend or set up a one-on-one meeting with me early in that week. Does that make sense? Because Friday's like the end. The grade books are closed by then. So I will send you guys out an announcement. I have a Monday afternoon class and a Tuesday afternoon class. So you guys will have to attend or at least pop into one of those to get attendance. And those classes are really short, 10 minutes, 15 minutes, and it's simply for students to get attendance. We go through any kind of end of the term questions or advising that we need to do. If I need to meet with you separately, I'll be reaching out to you. Okay. So that's what happens with Friday classes in week 12. You've got to try and attend a class earlier in the week to get attendance. Mondays I teach at 3, Tuesdays I teach at 1, but I'll send that out to you in an announcement. Does anybody have any questions about that? Because that's pretty important for Friday class. So week 11, after you take your HESI, I would suggest you try and do your remediation as soon as possible. Okay. In this announcement, I posted what the remediation guidelines are. Okay. And that's the time frame that's needed to, the hours needed to complete your remediation based on your HESI score. And that shouldn't be unfamiliar to anybody. Just say nothing's changed since last term. Okay. And then the review schedule that I sent you. Okay, so get your remediation done as soon as you can after you take your HESI. Remember also during week 11, when you take your HESI, for this class, you still have your last NCLEX assignment that's due, the 4th NCLEX assignment. That is due in week 11. And I'm only taking the time to review this with you week by week because there's a lot. Okay? After week 11, on that Sunday, March 24th, I cannot accept any late work. So if you're late with your HESI, I can't accept it. Okay, if you haven't turned in your vulnerable populations assignment from week 10, and you're going to take that extra week to do it, that's 7 days with a 10% deduction. I can't accept it any later than the 24th. Okay, so no late work after the 24th. Okay. And then lastly, week 12, your remediation is due no later than that Monday of week 12, Monday, March 25th. Okay, if you don't get your remediation done by Monday, March 25th, your score for the HESI gets recorded as a 0. So you got to have that in by the 25th. That's why I say as soon as you finish your HESI, as soon after that you can complete that remediation. And then once you complete remediation, I'll post the grades in the grade book for your HESI. I can't do that until you've done your remediation. And I'm checking all during the week after you take your HESI. A lot of students email me, they've completed their remediation. That's fine, but I'm also checking every day as well. Okay. And then we already talked about you'll need to attend class during week 12, but it will be the Monday or Tuesday class. Okay, so that's a lot of information. Do you guys have any questions about any of that? A lot of people have actually, oh, go ahead.
So if we can't attend the Monday or Tuesday in week 12, we just have to email you to set up a different time?
Yeah.
Okay.
Yep. Just email me and we'll do a one-on-one. And it's really just kind of end of term check-in. Yep. And we can do that. Grade books are closed like Tuesday evening, Wednesday morning. So if you don't think you can attend the class Monday or Tuesday, you've got to reach out to me and schedule something. We'll have to meet Monday or Tuesday, or maybe even over the weekend prior. That's fine too.
Okay.
Does that help?
Yes, it does.
Okay. Questions about anything? It's a lot of information. And I know you've got other classes that are probably doing the same thing with you, reviewing the rest of the term. Anybody have any questions? Okay. Randy, if you could come on camera, that'd be great. I don't think we have Jasmine. Okay. So we're going to go through week 9 content, go through our last 2 concepts, which is cultural competency, and human abuse and violence. And then we'll do our week 9 case study, which is about cultural competence. Okay. And then we're done. Questions?
Hey, can you move?
Hi, Brandy. Okay. Oh. Okay, can everybody see my screen? All right, let's first talk about human abuse and violence. When we talk about human abuse and violence, what are we talking about? What kinds of human abuse and violence might we be either taking care of clients that are victims or perpetrators?
Children and elderly being abused and being like mandatory reporters on abuse.
Okay. What kinds of human abuse and violence might we see? Elder abuse, child neglect. What else?
Pregnant woman abuse.
Pregnant women,
Domestic abuse.
domestic abuse, intimate partner abuse. What about human trafficking? What about sexual assault? We have murder, we have suicide, we have assault, what other kinds of abuse might we see? Pardon me?
I said sexual abuse.
Sexual abuse. Okay, we know that violence is a maladaptive coping mechanism. We know that violence is increased, the risk increases in vulnerable populations, the homeless, teen pregnancy, people that suffer from substance abuse, mental illness. Okay. As nurses, over the course of our journey in our profession, we will probably care for lots of clients who are victims of abuse and maybe even some perpetrators of abuse. Right? People who are involved in violence typically have had some kind of previous exposure to violence. Abusers were often beaten when they were children, or witnessed siblings being beaten, or witnessed abuse between parents or guardians. Right? They typically learn that violence is a way to manage conflict. Some other factors, some other disparities that may play into human abuse and violence: increased stress, financial issues, living in poverty, living in communities with high crime rates, chronic diseases, complex chronic diseases, chronic pain, obesity, diabetes, hypertension. Okay, we as nurses are mandatory reporters. What does that mean?
We need to report any kind of abuse.
We mandatory have to.
Okay, is that in just the workplace or is that anywhere?
That's anywhere.
Anywhere. Anywhere. Could be the neighbor's backyard. It could be the grocery store. Could be schools. Right? Most commonly reporting child abuse, child neglect, elder abuse, elder neglect. Okay. There's a difference between physical neglect and emotional neglect. Physical neglect refers to for basic needs, failure to provide for basic needs. Food, we had a quiz question about this last week. Food, clothes. Pardon me?
Not providing necessary medical care.
Not provided for is a neglect. It's kind of abuse.
Yep. So your physical neglect refers to basic needs: food, clothing, shelter, hygiene, and medical needs. Emotional neglect would be the omission of nurturing, caring for somebody, right? Caring for essential health and development, being aware of growth and development, or not being aware. We know that kids who are exposed to violence, whether they're victims or witnesses, are at higher risk for mental disorders. They're at higher risk for self-harm, they're at higher risk for substance abuse, and they're at higher risk for suicidal ideations. We know that abuse is about power and control, and all these methods of abuse are about control. Family violence. Okay, family violence is typically violence between the most powerful against the least powerful. Family violence is usually perpetuated in cycles. Children grow up seeing violence as a method to use to control over the kids, over the partner, over the spouse. Okay, abused children are more likely to perpetuate violence or tolerate violence in their own relationships as they get older. Family issues, family risks that may be going on. We talked a little bit about this economic strain. Maybe there's an unplanned pregnancy, unemployment, marital strain, infidelity. These all increase the risk of violence. Social isolation contributes to violence. Okay, social isolation, where you have a lack of social support, you have a lack of community resources to help cope with any of your crises. Elder abuse is actually a type of family violence. Okay, so if you're going into a home and doing a home visit, what kinds of things would you be looking for? We'll go into the book and talk about this in a little bit, but what's elder abuse? Very common.
Abuse,
What are we looking for?
economic abuse.
People taking advantage of the elderly, like, and this is to include their finances as well as physical, emotional, and mental abuse.
Right. Anybody ever witnessed elderly abuse? I've had several stories from
have.
students this week talking about elder abuse. What was your situation, Megan?
I was activities director at a skilled nursing facility for a little while, and previous to that, I was a CNA there, and I'm still a CNA there now. But while I was working in activities, I had this new lady get introduced to our population there, and she was super happy and like very spiritual. And so then I started working with her, and she started like doing little church groups and like morning affirmations and stuff with our residents, because it gave her a sense of purpose to like be able to have sermon and prayer time and stuff like that. So we like made it a part of our daily schedule. And she was just a happy lady, and I'd never met any of her family members, and I hadn't seen anybody like come in to visit the first few weeks.
Mm-hmm.
But then her daughter showed up to sit with her at dinner one night, and dinner was always served in my area. And when she sat down with her, you could see this lady's like whole face and demeanor change. Like, this is her daughter that's coming to visit. You would think she'd be excited or happy or talkative or something, but instead it was like her entire face just dropped. Like, she became apathetic to everything. Like, you know how when they say you see it in like Parkinson's where there is no emotion at all, that's how she shut down. And I'm like just kind of watching and listening as I like walk around and serve people their dinners. And she was controlling this woman's every move, straight down to what bite of food on her plate she should take first. No, Mom, no, don't eat that. Eat the meatloaf first. And I'm like, what the heck? And then she was telling, like, Miss Betty asked me for a cup of coffee. And when she asked me for the cup of coffee, her daughter was like, don't listen to her. She doesn't know what she's talking about. She's never drank coffee before in her life. And I'm like, well, she's been drinking coffee here with us and the ladies for the last like 3 weeks. So maybe she likes coffee now. Like, who are you to tell her she can't even drink coffee? Then I started noticing, like, at nighttime, I'd walk her to her room to put her to bed, and her daughter would be on the cell phone, and she would be listening to us as we provided care for her. She was to go to bed at a certain time every night. If she wasn't in her room in bed when she called that phone, then she would be in there. The daughter would like come into the facility and make her go to bed. And I called the ombudsman about it. And then the ombudsman came in and did an investigation and like kind of had to interview Miss Betty and talk to the daughter and kind of like sit back and even just watch the interaction between the two. because Miss Betty could hide it, like maybe she's scared about getting in trouble or whatever. So she just wanted to see their interaction
Right.
as well. And, you know, things had to be put in place. I think that they were too lenient, because it's still sometimes happening. Like she'll come in and do things, and I'm like, this is against our little like agreement that we have
Mhm.
with you about like
Mhm.
you won't be allowed in the building if this continues. You know, so I have to continue to watch and report because things need to be updated.
Absolutely. Thank you for sharing.
That's
Yeah. Anybody else have any experiences with the elderly?
So when I was in my clinicals, 2 times I was with the elderly doing care activities of the daily life. And the families are there, and as soon the families go out, the daughters, they say, "No, let me alone, I'm with her," or something. Yeah, they was scared about their own family.
Sure. You know, what about the elderly relative who's still living in the home or moves into the home with their family members and they want to take over all their financials? Right? Maybe there's some abuse going on there. You never know. But part of your job as a community home health nurse, if you're doing the visits, you have to do with the elderly, well, even with the kids as well, but you have to do safety checks and you have to be looking for risk factors.
And I might add, you might want to watch your coworkers as well, because
and your coworkers.
I see it a lot in nursing facilities where you like go behind somebody to take over patients, and there's people that are sitting there like soaking wet that should have been changed hours ago. Or, you know, people with food in their beds because nobody's changed their sheets. And it's like really disgusting and sad to see that kind of stuff happen.
I had a student share with me Monday of she witnessed a coworker actually physically slapping one of the clients. This all, I mean, if you think about it, the age of our population is growing, right? People are living longer. So therefore elder abuse is going to become more common, whether it's in the home, whether it's in a family member's home, whether it's in a facility, whether it's in the hospital. I mean, think about domestic violence. Has anybody ever cared for a domestic violence victim in the hospital or in an urgent care or in a medical office or visited in a home visit? What do you see there? What typically do you see there? Anybody ever had that experience?
Yes, I saw the same as other clinicals. A person who came in with trying to suicide because the husband problems. She abused about medications, tried to suicide. She have bruises.
Mm-hmm. You know, over the course of your career, you're going to be caring for a lot of people that have either been victims of violence, even some perpetrators of violence. How do you feel about that? How do you speak?
Was another thing too. Like I had a little lady that came in, and her husband and her had lived together, and he also had like some mental disturbances, and there was like domestic violence on their record. She fell and broke her hip, and he refused to call her help and made her lay on the floor for over a week. And then he said he couldn't stand the smell of her anymore, that we needed to come and get her. And by that point she had a like gaping wound on her hip where she had laid on her side for so long, like in her own feces and urine. And then what was crazy is like once we started like getting her patched up and she was like all in bed and feeling comfortable again, the first thing she wanted to do was call and talk to him. Or like he would call us wondering when we were going to discharge her because there's things getting behind at home. And I'm like, we didn't ever end up discharging her to him. Thankfully, we were able to put protections in place and she stayed with us long-term care. But, you know, she was admitted to skilled to be there quickly. and thankfully we were able to get.
This is a common occurrence. This is a common occurrence. In the schools where I worked for 21 years, I would say 2 or 3 times a week, I was making mandatory reports to social services with regards to potential child abuse, potential child neglect. It's everywhere, right? And as our communities are getting more high risk, we're starting to see more violence, more mental health diagnoses with kids, adults, more stress factors in our communities. That is leading to much higher rates of violence. Are you seeing that in your communities, or as you're doing your clinicals, or out in your workplaces? Are you seeing this? Anybody? I know it's early Friday morning. Everybody looks like they're. Has anybody had any other experiences? Okay. Okay, let's talk about some of the symptoms. Victims of violence exhibit symptoms for kids in particular. Kids may be prone to frequent headaches, stomach aches, maybe regressing back to bedwetting, anxiety, depression, maybe some withdrawn behavior, inappropriate sexual knowledge, sexual behavior, maybe precocious teens. Okay, maybe menstrual disorders are causing depression, anxiety, and increase the risk of them becoming victims. Top, intimate partner homicide. Okay, this is attached to intimate partner violence. One of the top risk factors for intimate partner homicide is a previous domestic violence incident. Other factors that contribute to intimate partner homicide: access to guns, maybe estrangement, threatening to kill, threatening with a weapon, maybe non-strangulation or non-fatal strangulation. Okay, abused women, chronic headaches, palpitations, sleep and appetite disturbances, sexual dysfunction, maybe some irritable bowel syndrome from the stress, UTIs, recurrent vaginal infections, very common. If they're pregnant, we know that violence, the risk of violence increases during pregnancy. Okay, so there may be more miscarriages, preterm birth, low birth weight infants. Okay. So how do we, as nurses, how do we begin to communicate with victims of violence? Non-judgmental, right? Giving them the opportunity to report, tell their story without feeling guilt or shame. Those are common emotions with victims of violence: guilt and shame. They don't want to talk about it. Right? But if we are working with parts of the population who are victims of any kind of violence, we have to find a way to successfully, or have to find a way to communicate with them in a non-judgmental way. Right? What kind of support do they have? Do they have family support? Are they out on their own? Do they, like Megan said, do we want to send them back into a family or into a situation where it's partner violence? Lots of things to think about. Elderly, we started talking about that. Risk for lots of kinds of violences: physical violence, emotional violence, or neglect, emotional or financial abuse or neglect. Emotional abuse with the elderly includes behaviors like name calling, demeaning, trying to hurt their self-esteem, scaring them, maybe embarrassing them in front of family members, destroying property, not letting them see family and friends, fear of abandonment, the elderly client maybe fears that if they don't comply, the caregiver won't take care of them. They won't feed them. With regards to financial abuse, is there money, property, assets, or is all that being misused? Suicide. Does somebody need to mute for background noise, please? Okay. Thank you. I appreciate that. Suicide is another type of violence. Okay, it's obviously self-directed violence, right? It's the second leading cause of death in young adults, ages 10 to 34. Some leading risk factors with suicide: depression, other mental disorders, or substance abuse disorders. Other risk factors, maybe a prior suicide attempt, family history of suicide, family history of mental disorders, substance abuse or violence, firearms in the home. Maybe somebody's been incarcerated. Maybe they've been exposed to, if they're younger, maybe they've been exposed to peers who have either committed suicide or attempted suicide. Okay. I just want to review some primary prevention. And this is what we did in the schools a lot, right? School-based education programs for the younger population. School-based programs on how to cope, how to reduce stress, how to reduce anger. And it was pretty easy to pick out the high-risk kids in the school setting, especially the middle school and high school settings, of students that we wanted to work with, to try and, we knew they were at risk, to try and give them appropriate coping skills. We also work with parents, trying to help parents and teach parents good coping skills, good parenting skills. We had
Professor,
home
I
visit.
have a question. Sorry to interrupt you. Well, what is the
Pardon me?
Sorry to interrupt you.
I can't really hear you, Celine.
Can you hear me?
A little bit better. Go ahead.
Oh, okay.
Yeah, much
About
better.
in the schools, what is the signs and symptoms of how they see in the kids they have problems for abuse, to be abused?
So we would see inappropriate behavior, aggressive behavior, maybe issues with drug use, fighting, bullying, harassing, right?
Okay.
Language, treating adults with disrespect.
Couldn't it go the exact opposite as well? Like people just, is it different with elderly than with children as far as like coping mechanisms and defenses, like where they shut down and everything? Do children shut down as well, or do they act out more?
Well, it depends. I mean, some of them are perpetrators, some of them are victims. Victims are often, at least in the schools, what I saw, victims are often quiet, right? Don't want to talk about it, or scared to talk about it, or scared about retaliation. So victim behavior is very different from perpetrator behavior. Perpetrators are the kids, at least in the schools that I was in, the kids who are acting out. Kids who are getting suspended or expelled for whatever, fighting, bringing things to school they shouldn't be bringing, threatening other students, harassing other students, bullying other students. And I think I brought up the example earlier when we talked about the school nurses. Let's say you have that student who comes in at the same time every day. They have a stomach ache. All right, it's after fourth period, whatever. They have a stomach ache. Well, after a week, we figure out it's not a stomach ache, right? What are they really there for? Right? Well, a lot of students use that clinic as kind of a safe space. And so you may find that there are other things going on. Why are you here at 10:30 every day with a stomach ache? What's going on? Well, if you probe with different kinds of questions, maybe you'll find out that, well, the girls in the next period class are harassing me or bullying me or name calling or threatening me. Right? So those may be victim reactions, but victim behavior and perpetrator behavior are very different. Right? Think of the woman who comes into urgent care that's been a victim of domestic violence and her partner's with her. She's much less likely to be talking about what's going on, right? She's scared. And maybe that perpetrator who's standing right next to her is the one answering all the questions, is the one not letting her speak, is the one making sure she's not saying something she shouldn't be saying about what happened that brought them there. Does that help, Megan?
Yeah, so we just have to be really aware and like look for cues, because
right. And you have to be comfortable talking about it. You have to be comfortable addressing the issue. And that takes skill. That takes a lot of work with therapeutic communication and good communication skills and non-judgmental and checking your own. I mean, what about caregivers who are trying to communicate with victims of domestic violence? Let's say the caregiver themselves has been a victim of domestic violence. How does that affect their care?
you would think that it would be like an unparalleled kind of thing. Like,
Or is it triggering?
I think it depends on the person and
Exactly.
where they're at in their recovery process, for sure.
Exactly.
If it's two people that are brand new to dealing with it, then I can see how that could be a train wreck kind of situation. But
Sure.
if the person that experienced domestic violence in the caretaker role and it happened a long time ago, I can see how it could also be beneficial and therapeutic, because you see that a lot with addicts and mental health as well.
Exactly.
They say an addict helping another addict is without parallel, and it's true. I feel that I've gained a lot of help from other people in the program. And it is helpful if you have somebody that's moved along in that recovery process. It can be super beneficial.
Absolutely. I mean, just think of all the violence that goes on in our communities. There are victims. There are victims that will end up in urgent cares, in hospitals. And there are also perpetrators who will end up in healthcare facilities that we may be caring for. When I first started at Fortis, I had a crazy example when we were talking about human abuse and violence of one of the students. Her sister was an LPN and worked in a correctional facility or in a prison, and one of the inmates was actually in there for murder, and he had killed a relative of this person, of the nurse working in the prison. And so obviously she had to make some personal decisions of whether she was going to even be able to care for this inmate who had chronic illnesses. I think he had diabetes actually, and had to have insulin injections. I think I remember that. And so her dilemma was, can I even care for somebody who is here that has actually killed one of my family members? And as it turns out, the resolution was that this inmate was moved to another facility because this nurse was unable to provide competent care. I mean, that's a pretty extreme example, but that was a legitimate example. Which brings us into our last topic, cultural influences of nursing. I love finishing up on this topic because cultural competence is so important in our journey as nurses. You know, after 40 years in nursing, I'm still trying to be, I consider myself culturally competent for the cultures I've worked with up to this point. But it's an ongoing journey. You know, I may have students next term from a different culture that I haven't worked with yet, right? That I learn about their culture. So cultural influences in nursing is our last concept that we cover, right? What is culture? After we go through the notes, I want to go into chapter 14 of our fundamentals book and share with you a couple of things. So we'll pull that up, but let's go through culture. Culture, we're all from different cultures. Our culture, and I'm speaking for all of us now, is everything that we believe true about the world. Okay, culture encompasses values, beliefs, assumptions, practices that we pick up throughout our life from childhood. As children, we're born into certain cultures, and we grow up learning what the beliefs, values, expectations, assumptions, practices are within those cultures. Different ethnic groups have similarities. There are a lot of differences. But we have to remember that we're all unique because we grew up differently. When we think about different cultures, we think about a wide range of behaviors. Cultures have different languages. They have different perceptions of touch. How close, personal space, how close do you want to get? Body language, whatever their perceptions of health and illness and recovery are. Culture affects our family structure. It has bearing on what we think about childbearing practices. We talked about different time orientations. Some cultures are past focused, present focused, and future focused. So as nurses, we have to be able to approach each client, each patient in whatever setting we're in, inpatient, outpatient, home, in the community. We have to approach each patient as being unique. And we have to learn about their culture. How do we learn about their culture? We observe, we do assessments, we talk to clients, we talk to their families. And it seemed like every fall I started back in school nursing, we had groups of schools. We weren't just assigned to one school. So I'd have up to a dozen schools. It seemed every fall there'd be a school that would have a different culture that I hadn't worked with yet, of a population in a community that the kids were coming to this particular school. Right? So it was always a learning process, always. Right? The other thing we need to do is understand our own cultural beliefs, our own values, our own prejudices, our own biases. We have to be able to check those before we care for clients in other cultures, right? We don't want to, we need to avoid judging and stereotyping. And that's what chapter 14 in your fundamentals book that was assigned this week talks about. What else? Let's say you're the community nurse and I'm just going to pick Vietnamese culture. Let's say you're starting a new job, you're a new community nurse in a new population in a new community that has a high Vietnamese population. And you don't know much about that population. Here's where we go back to the trusted community leaders, right? Who can be on your team to help teach you how to work with a newer population that you're not familiar with. So we can use trusted community leaders as an entry point to being introduced to these populations. They can help us through that assessment phase of what does this population need in your community? Either do they have kids that aren't immunized? Do they have chronic diseases? Do they live in poverty? Do they need resources from within the community? Right? So our trusted community leaders can help us work with that community. We also may have large parts of the population that don't speak English. What do we do? How do we communicate with this population? Okay, we always have to have. Okay.
Translators.
Go ahead. Go ahead, Megan.
I was gonna say professional translators.
Yep. Translators is always the first option, right? Interpreters, translators. I mean, we can use family members to help us, but how do we know their reading level and their competency level? Right? So interpreters are always the first, most important in their native language, but we can also, like this says, use printed material, right? Radio announcements, newspaper articles, all in the primary language.
I have a question.
Yep.
So if there was a question, I don't know if this will really happen, but if there was a question that stated that like the patient spoke a different language, but an interpreter was like busy or couldn't come, what would the paper information be the next best thing to
Yeah.
give the patient? Okay.
Yep. In their primary language,
Okay.
right? Trying to maintain an open and objective attitude towards individuals and their cultures. Okay, avoid seeing individuals as alike. We don't expect to be treated, you know that saying, treat others like you want to be treated. Well, different cultures have so many different variations, right? That we can't expect to be treated as they want to be treated. Every culture is treated differently, right? We don't want to be projecting our own beliefs of our own culture onto others. Okay, so cultural awareness is our self-examination of our own biases and prejudices, right? If we lack cultural knowledge and competence, we're not going to be doing a good job caring for clients of other cultures. And throughout our journey as nurses, we're always going to be working with different cultures, always, right? I want to read this. I love this. This is a nice summary before I jump into the book. We're all, as nurses, striving to be culturally competent. Okay? In order for us to ongoingly develop our cultural competence, we have to be sensitive to cultural implications during each encounter. Avoid stereotyping, whether it's based on age, race, ethnicity. Always ask questions to stimulate your learning and learn about the client's culture. Avoid making assumptions about nonverbal cues from the clients from unfamiliar cultures. Right? Try to always be learning and discovering information about the various cultures. That should be a priority. Okay? Using a variety of sources. You know, whether it's attending a cultural event in the community with that particular culture, whether it's reading and researching, whether it's asking a coworker who may be of the same culture, asking the family members, asking the patients themselves about their culture. Right? We can't assume that our culture is better than anybody else's, or our practices are better than anybody else's, or our values or our beliefs. Okay? Cultural competence is an ongoing learning process. Okay? I feel after 40 years in nursing, I feel very confident that I'm culturally competent. I've worked hard at it. I've been exposed to a lot of different cultures in a lot of different settings, but it has helped me grow in my practice, helping me be more knowledgeable, me being more tolerant, me being more educated, right? Because we're all going to be engaged with learning to care for clients of different cultures, right? I want to go to the book here and show you a few things in chapter 14 that I want you to meant to pull this up. Let's see. Fundamentals. So I'm going to chapter 14, which was part of your reading for this week. Okay, and there's a couple things that, can everybody see this? A couple
Yes.
things I want to point out. Okay. This is a really nice summary about what is culture. We've already reviewed quite a bit of it, but I want to talk about a few more things. Culture, beliefs, values, assumptions that is shared and maintained by a particular group. Okay? Culture is learned and acquired. Culture is shared by a certain group. Culture is incorporated into our identities. Okay, and the last is culture is dynamic and it changes under influences of shared experiences. Okay. This is a good section for you to read. Developing cultural competence. It's a summary. Remember, most of my notes that I do for class come from the book. Okay. Developing cultural competence. This statement is wonderful. Cultural competence involves knowing yourself, examining your own values, examining your own attitudes, beliefs, and prejudices, keeping an open mind, and trying to see the world from a different cultural perspective. Some barriers to cultural competence. Stereotyping, we all know what that is. Prejudice, another barrier. Ethnocentrism, thinking our culture is better than, my culture is better than yours. Cultural conflict happens, okay, when there's a perceived misunderstanding. Okay, cultural conflict is common. Okay, there's a perceived misunderstanding of expectations. Maybe the nurse is unable to respond appropriately to what the client's needs are. Okay, we're always striving to include the culture's beliefs, practices, values into the health plan, right? Cultural conflict may be a misunderstanding of why a certain practice of that culture can't be incorporated into the health plan, right? Conflicts, they're unavoidable, but we can do whatever's necessary to minimize the impact. Cultural shock, on the other hand, is really the extreme, right? When you as the caregiver are unable to care for somebody in a particular culture, right? Because you their values and beliefs are so radically different that you just can't participate in that care. Right? So cultural shock is the feeling of helplessness, discomfort, maybe some disorientation with an individual with you trying to understand and adapt to a certain cultural group. And at that point, you can't care for that client. You have to find somebody who can. Some cultural differences, some areas of cultural differences. Communication, view of time, personal space, family and social organizational structure, nutritional practices, maybe issues related to death and dying, their beliefs on healthcare. Those are all areas that are very different. Okay, different cultures. I want you to have a look at table 14.3. It's on page 196. I'd like for you to have an understanding of the particular 2 of these 6 cultures that I highlighted, the Hispanic cultures and the American Indians. Okay, and this is a table that goes through 6 common cultures: Asian Americans, Hispanics, African Americans, Indians, European Americans, and Arab Americans, and some of the common cultural values, practices, and beliefs. Okay, and I've highlighted 2 of the 6 that I'd like for you to be familiar with. Can everybody see that? It's fascinating. It's a fascinating table to have a look through. Okay. The other part of this chapter I wanted you to review is at the end, key points. This is a really good summary. You're responsible for the whole chapter. So this is a really good summary of the important points in the chapter. Okay. So those are the areas that I want you to take a look at. How are you guys feeling about cultural competence? Are you learning different cultures as you're going through your clinicals, your interactions in your community, maybe with the school community? What's your experience with cultural competence so far? Cultural knowledge, cultural awareness?
So I have my own experience where I'm from Mexico. So when I came here the first time, I was like cultural shock. I don't know what to do.
Yeah.
Language, different uh, personality, beliefs, everything. So, but I start to learn little by little, and apply. So I know like Philippines people are very Catholic, or kind of language they talk the Tagalog or the food versus the people from Middle East. They believe the different religions they have. All this was like, okay, I'm still learning. Plus the language barrier that I had before. It was
Absolutely. Yeah.
I don't know. And then the laws from the United States, how to know all the how to manage myself here. So yes.
Yeah. So think of Celine coming in from a different country, being pretty unaware of our practices. Think of other clients coming from other countries or family members from other countries that have no idea what the language is, what healthcare is about, how to access it.
Right.
Right? I mean,
for example, in my country, we have the vaccine for the tuberculosis. So when I came here in the school, they asked you for the TB test, and they show positive, positive, positive.
Yeah.
But it's because I have the vaccine. So they send to me to the healthcare provider. They ask me to exercise, demand to test, and send to me to the how's called this place? Um the health department
Hmm.
to check and everything. So they say,
Mhm.
no, you have the vaccine, you have immunity, so you have the living virus like numb in your body. That's why they show.
I mean,
It was so
yeah. I mean, if you think about it, I mean, we are working with and maybe going to school with and maybe living next to in our own communities, all different people of all different cultures. It's up to us to be culturally knowledgeable, culturally sensitive, culturally kind of inquisitive about learning about new cultures. It's gonna happen through our whole journey in nursing. We have a lot
right.
of students at Fortis that are English is their second language, right? So even with me as a instructor, I'm learning fascinating information about students from different cultures, here in this program. I consider it, I love learning about students and new cultures and maybe study habits or that's okay, Megan. Thanks for the update. It's fascinating. I've loved every part of learning about different people, different cultures, different practices through my whole nursing career. So, okay, I'm going to send you guys into some breakout rooms. We're going to do a cultural competence case study. It's actually really good. It kind of reinforces everything we've been talking about the last 30 minutes. We'll go into the breakout rooms for maybe 10 minutes. You guys come up with your answers. Breakout room 1. So the case study is in your announcement I sent over the weekend. That's one of your four attachments. So you guys pull up the case study. Okay. Let me get you into rooms. Room 1 will have question 1. Room 2 will have question 2. Room 3 will have question 3. Room 3 will have question 3. I think you'll like this case study. Skylar, can you get into that room?
Because in the paragraph it says the first, well, basically like the first, she don't speak the same language, so the first thing she do is obtain a interpreter. So
I didn't even read the paragraph. I just went to the question.
yeah.
Really?
Why is there a call?
Because I'm at the dentist waiting for Gigi.
Hey, Jasmine, I can't have you in the car. I'm sorry.
Hey. Yeah, I was at the dentist. Do you want me to go into the dentist?
No, yeah, I can't. Yeah, I can't have you in the car.
All right.
You guys find the case study?
Yes.
Okay.
Okay.
Are you guys coming? Did you find the case study? Talking about it?
Yeah. Yeah.
You already know. So then cultural awareness would be the one before that. And then I think desire would be the very first.
What you guys think of that case study?
That album was a song titled Ultralight Beam, which he sampled from this little girl, 4-year-old Natalie Preach. Now her video has been
Somebody
seen.
needs to. Yeah.
I mean, she even made it on the show Little.
All right. So we have Nancy, a public health nurse who's working in a clinic that provides services to a community of Hmong immigrants. These individuals are applying for immigration visas and are required to undergo a medical screening. Primary purpose of conducting these examinations is to determine the presence of any communicable diseases and to vaccinate according to CDC guidelines. Okay, so that's your background information. So Nancy is typically the first person to initiate contact with new immigrants. She doesn't speak the same language as individuals who report to the clinic, but she has access to an interpreter, so that's good. She's aware the clients are nervous about seeking care because they are unfamiliar with U.S. health practices. Okay, so group number one. What did you select for the right answer? The public health nurses providing service to recent immigrants should be most concerned about which of the following? What did you guys come up with in group 1? I know you can see the right answer, but did you come up with B?
We were stuck between A
It's
and
in
B.
group 1. Pardon me?
We were stuck between A and B.
Okay. Well, A, she already says she has an interpreter,
Oh, okay.
right? In the background information. So it says that the primary purpose of conducting these exams is to determine the presence of any communicable diseases, right? So her primary concern is going to be being knowledgeable about high-risk diseases of the population, right? Right. So the rationale for B, nurses need to know that what kind of risk factors are given, what kind of risk factors are present for any given immigrant population. It gives an example of Southwest Asians are often at risk for hepatitis, TB, intestinal parasites, vision, hearing, dental issues. Okay, so the teaching part in this rationale is here. Okay, when working with immigrant populations, we talked about this in class. You have to consider how your own beliefs, knowledge may be significantly different from those of the people that you're providing care to. Language barriers we talked about may interfere with your job of what you're supposed to be doing. Okay. Group 2, what did you come up with?
B and E. B is in boy, E is an elephant.
Great. Awesome. So Nancy, the nurse, is working, she speaks English and Chinese, but she does not speak the language of the Hmong immigrants who speak Laotian. All right. So, yes, B, the nurse is providing care while paying attention to individuals' beliefs about pain, touch, modesty, and eye contact. All that plays into how we care for this particular client. That's what their culture is built on. And then the nurse provides care that acknowledges the difference in ways individuals respond to illness and treatment. Absolutely. So, culturally, let's take a look at this rationale. This is a really nice summary of what we've been talking about. Cultural competence. Cultural competent nurses function effectively when caring for clients of other cultures. Okay, nurses who strive to be culturally competent respect people from other cultures. They value diversity. This helps them to provide more responsive or competent care. Right, so cultural competence includes knowledge of the fundamental differences in the ways the clients and families respond to illness, treatment. Okay, we need to be mindful of dietary practices, pain control, death and dying, modesty, eye contact, closeness, this personal space, touching of others. Okay. Then number 3. So, Nancy attends a class at the local Laotian Cultural Center so she can learn more about the customs and practices of the community she's serving. What is this an example of? Group 3, what is it?
So we were between C and A, but I see the answer is D. But our train of thought behind that, I think, was desire is the want to. Awareness is like the going to the classes and trying to become knowledgeable. And then cultural knowledge, I thought, would be the very last step where you pretty much know a lot, but you're still learning. So I didn't think that she was at that stage yet by going to the classes. So our answer was C, but I see the right answer is D.
Yeah, let's read the rationale and we'll explain all of these 4 choices. So cultural knowledge, the correct answer, is information about whatever the elements of diverse cultural and ethnic groups you're trying to learn about. So by going to that event, they're gaining cultural knowledge, right? So the emphasis is learning about the client's worldview from a perspective. Okay, an understanding of the client's culture decreases misinterpretations and misapplications of knowledge and facilitates the client's cooperation with whatever you've determined is their healthcare. Okay, so does that make sense?
I still don't understand. Can you just explain to me what the difference between C and D are?
C and D. Okay. Cultural awareness, it's right here. Cultural awareness, which I think was C. Cultural wellness is a self-examination and in-depth exploration of our own beliefs. Right? And then cultural knowledge is the information you're seeking about other cultures to be able to effectively care for them. You said cultural desire refers to the motivation.
So, I'm sorry.
No, go ahead.
So the awareness is you kind of like teaching being aware of your own feelings and teaching yourself. And then the knowledge is going to the classes and actually learning about.
Right.
The
cultural awareness is simply being aware of what our own culture is, what our own values and beliefs are. So it's an awareness of different cultures exist. It's being aware. Well, cultural knowledge is actually taking the next step and learning about other cultures. Does that help?
Okay. Yeah, it does. Thank you.
Okay. So I'm going to send you, when I send you the recording of this class, I'm also going to send that extended version of the case study we went through that has the answers and the rationales, if you want to review that again, because the three rationales in this case study are excellent teaching points as well. Okay.
Okay. Thank you.
Yep. Anybody have any questions? Well, that concludes our content part of the course. And I love ending on the cultural competence concept. It just brings everything together about our profession. So if we don't have any questions, you guys are free to go. If anybody has questions, stay on after. Otherwise, we'll see you next Friday. Okay, so have a good weekend.
Thank you.